I'll walk with you.
Okay, thanks. Well, good afternoon, everyone. Welcome to this. Lourdes and I are a team here. She has the microphone and tied to the hip. So I'm delighted to introduce today's speaker, a friend and colleague from the University of Southern California, Lourdes Baezconde-Garbanati. As you can see, Lourdes has a lot of titles, and that's because she does a lot of things and is really the leader at the USC School of Medicine and reaching out to the community for decades, communities for decades, and doing work that is participatory with the communities, engaged with the communities, and building research that makes a difference. Much of that has been focused on tobacco, smoking for decades, but now on to many other things. And I think in recognition of that, she was given more duties and a lot of titles to do a lot of things. Her work is far-reaching, well-published, widely recognized, acknowledged, and some of it pioneering. Her work on cervical cancer and encouraging Pap smears and vaccination through a telenovela approach involving a chicken. You have to see the video to get the story. But that piece of work, funded by NIH, was widely acknowledged. At USC now, she has a lead in projects in the Tobacco Center of Regulatory Science related to the tobacco retail environment, work on tobacco and marijuana and vaping and many other things. So she has a lot to tell us about, a lot to teach us, and thanks for coming, Lourdes.
Thank you.
Let's see. If you can put that back on. I can do it.
I think I got it. Can you hear me okay? Great. Hi. It's great to see some of you here and to meet others. It's been a real pleasure being here. I originally come from the Caribbean, so you can imagine seeing the snow here. It's like, oh my God. This is like, it feels like magical because it's like being in another world. So thank you so much for inviting me, and I'm going to talk a little bit about some of the things that we've been doing related to our tobacco work in particular. If you do want to see the chicken, I can talk to you about the chicken later, but it is a really funny thing. Pretty much a lot of the work that I've been doing is with the Hispanic population, and part of it has to deal with the fact that the Hispanics are growing all over the United States and are expected to continue to grow exponentially over the next decade. And so here you see the population growth is quite large, and these represents very heterogeneous groups. So it's not just, for example, in California, we see a lot of individuals of Mexican origin, but it's really from all throughout Latin America, South Americans, Central Americans, and all of the diversity within that group as well. And I was telling some other groups earlier that we just received a grant to look at Amerindians, which are the indigenous people of the Americas, and especially from Latin America. And so we've just hired our first Zapotec, which is from one of the indigenous tribes in Mexico, to also help us understand some of the within-group differences in our several communities. So this is the percent of adults who smoke by race and ethnicity in 2017. And as you can see, California certainly has one of the lowest rates of smoking. But one of the interesting things about smoking rates in California is that although this rates may be lower, it actually masks what's really happening in some of our communities within the communities. So for example, even if you look at Asian and Pacific Islanders, Koreans and Vietnamese has very, very high rates of smoking, while Japanese have much lower rates. The same with several different Hispanic groups, with some groups having much higher rates of smoking, for example, Cubans versus other groups. And so these generalized data also tend to mask what's really happening with some of the populations really internally. So let's start off with what's it a name. So there's been all this controversy and all these questions about what do we call ourselves? Are we Hispanic? Are we Latino? Are we Latinx? Who we are? So I put all three of them. So I figured, so the Latinx term has been used more and more in recent years, and it's a much more inclusive term. It makes sure that we are looking at broader kinds of definitions of who we are. Hispanic Latino has been the more traditional terms, and Hispanic is still being used by the U.S. Census. So when we submit grants to the National Institutes of Health, we usually use Hispanic, but in our CVs and in other kind of our writings, we may use some of the other groups. So Hispanics and cigarette use, as you could see here, you have different groups that are using in different subpopulations, with Puerto Ricans being at the highest rate and Central Americans at the lowest rate. And then this is Cuban and Puerto Rico smokers in the United States. They're much less likely to quit than smokers from other Hispanic groups. So, so we also have those within group differences that we have to really, look at and explore. So Latinos in California, they represent about 38% of the total population, and about 10% of adult Hispanic populations in California are smokers. And so that, it really, in terms of numbers, it represents a little bit over 1 million Latino smokers. So still we're talking about that even if the rates are kind of low, we have large groups that are still represented in those groups that we need to take care of. So this is the number of adult cigarette smokers, and as you can see in the Hispanic Latino populations, we have, especially among males, larger rates than among females, which is kind of, you see that in other groups as well. Now, this is the data based on youth tobacco use by different demographic groups, and as you could see, we have issues with males as well. The LGBT community has been heavily advertised to, and in particular, the Hispanic as well as African American and other groups within these the LGBT community are particularly targeted. And then by race and ethnicity, you have incredibly much higher rates among certain American Indian groups and some Pacific Islander groups that we need to also attend to. So this kind of shows you where our demographics are in terms of the Latino population. Now, what's been more of a challenge for us more recently, and probably for you here as well, is the e-cigarette use. And some of the things that we have been exploring are Tobacco Center for Regulatory Sciences, of which John was the main center PI for the first 5 years, and now it's Dr. Adam Leventhal and Dr. Mary Ann Pence who lead the second phase of the Tobacco Center for Regulatory Sciences. And what we're seeing is a lot more increase in vaping as well. And one of the concerns is that, we're not really sure if it's the chicken before the egg or which one comes first, whether you vape first and then, then you get into other things, or whether, you start in the combustible and then, go into dual use. So there's still some of that has not been completely defined, but it seems to be that there is a trend in subsequent both cigarette and cannabis use in these populations, especially among youth. Menthol cigarettes is really a big problem. It is especially a problem among the African American population, followed by American Indians, and certainly 33% of adult cigarette smokers that smoke cigarettes in California are also Hispanic. And so when we tackle some of these issues really head on, we have to look at the issues related to menthol, because it's a lot easier for people to start smoking because of that. So that's kind of like something that we've been exploring. We also had a recent paper that we felt made a big difference in terms of policy. Dr. Adam Leventhal from our Center for Regulatory Sciences published on November 4th a paper that showed that the most preferred flavor among youth of the e-cigarettes was mint, and it was the mint Jules flavor. So what the benefit of having published that and having really advertised and made sure that paper was promoted heavily was that by November 6th, Jules took out mint as one of the flavors because they were worried about the regulation. And so what you see is how you can totally utilize science. And our study was funded by the FDA. So there was a bit of FDA action behind it. And we believe that possibly Jules was concerned about the regulatory authorities coming down on them really hard when we could really prove that that was the main mechanism by which youth were really attracted to these cigarettes. And so you could see where the science base can still make a difference in terms of the things that happen in the practice world as well as in the real world, and why we need to have this science base to really move forward programs, especially in public health. This again is just showing the effect of menthol. Also, hookah is really a big thing in many of our communities. There are hookah parties, all sorts of things, especially university settings like this one, and many, in our own communities. And although there's fewer percentages of Hispanics, now it's like we're not completely clear about what's being mixed and what are the things that are, inside that, and what are the chemicals and things that people may be getting exposed to through that. So 50% of Hispanic teens have said that they use marijuana in the past year in a 2011 survey. Since now marijuana has been legalized in California, we suspect those numbers are a whole lot higher. And so now there is this concern about what is called the triangulum, which is the use of marijuana, combustible tobacco, with the electronic cigarettes as the smoking delivery device. And so that it's now a combined use of 3 different products. And we don't really understand what are the consequences or the effects of that quite yet. So I'm now going to turn to 2 of our studies in particular and tell you a little bit about how we went about conducting them and working with our community health workers in doing that. Many of our projects are community-based participatory research projects, so they include our communities very actively engaged in the things that we do. I'm going to start with a little video which shows you the reasons why we decided to work on the retailers responsive to the FDA regulatory authority in minority communities in particular. And this is a video from the California Department of Health Services that we work very, very closely with. But it shows you the reasons why we're behind this whole work.
This is Antonio. He loves building things and solving puzzles. Antonio doesn't realize it, but there are companies who are after him. Antonio walks to middle school every day. Along the way, he passes by stores that have one thing in common. They all sell cigarettes and a lot of other tobacco products. In fact, in California, there's a store that sells tobacco for every 254 kids. So why is that bad? Because tobacco companies place eye-catching ads in these stores, which influence our kids to smoke. And many of these stores are within 2 blocks of schools. You may be surprised that research shows tobacco ads are more powerful than peer pressure. So you may not have seen tobacco ads lately, but Antonio sees them every day in his neighborhood and is nearly twice as likely to start smoking. Stand up for our kids and protect them from a lifetime of addiction. Learn more about what you can do at tobaccofreeca.com.
So that's kind of like the impetus behind this whole study, working with the retailers in the retail environment and trying to understand what's going on. One of the important aspects of the study is that we were probably one of the first, if not still the first, to really not hold a sting operation, but actually go into the retail environment in multiple communities up front and talk to the retailers directly and actually interview them and also survey their store and audit their store with complete knowledge of what we were doing and a really total openness. That was only possible because we hired 27 community health workers from each one of 5 different communities. Our communities represented American Indians, both within and outside tribal lands, Korean Americans, Hispanic Americans, African Americans, and we went into certain neighborhoods that are predominantly Russian and Armenian with really high rates of smoking. And we trained these community workers to work with us on these communities. For some of them, for example, for the Hispanic community, we even had to translate the IRB so that they could actually take the IRB exam and be certified, and we translated all of that into Spanish in order to allow them to be able to do that, because the work they were going to do was in Spanish. And so that kind of tells you the importance. And I'm going to tell you a little bit about how critical it was to make sure that our community workers were involved. So this project in particular examined the knowledge, attitudes, and beliefs of independent retailers in vulnerable ethnic communities. And we also wanted to understand what were the most effective ways to communicate information. You know, we're all about public health and communication. So in what ways can we communicate to different groups, to different ethnicities? And then examine what were some of the opinion leaders' perceptions of this. So we had the different groups that I mentioned, and in addition to that, we had a survey, and we also held a series of focus groups. So it's a mixed methods kind of design, and we were able to get data among 800 retailers in these different communities, and also to be able to audit their shops as well. So this is a map of LA County, and as you can see, the county is very, very vast and very large. It's composed of over 10 million people. And so, you know, our work is really cut out for us when we need to work within the county. And then on the right-hand side are the tribal lands and rancherias in California. And Dr. Clara Dina Soto represented a lot of the work that was being done in the American Indian population and oversaw some of that work for us, and she is Pueblo Indian. So these were our interviewees. So a large percentage of them were clerks. Some of them were managers, and to a lesser percent, some of the owners. The demographics, you know, they came from several of these different communities, and you could see that there were different levels of English literacy in these populations. So imagine when the FDA is bringing out educational materials and they are, you know, in English and maybe not necessarily at the right literacy level as well, it does produce a certain amount of problem. One thing that we're very careful about is really examining even the materials that are used, even if they come from the FDA or from any other source. One of the materials that we were working with, we realized there was an error in the translation. So the material was material that was supposed to say, you know, do not sell to minors. But in Spanish, the material didn't quite say that. It said something different. Before I tell you what it said, what you need to realize is that we're in Los Angeles, where the largest percentage of stores that sell tobacco tend to be Korean-owned, and they are in African-American neighborhoods as well as in Hispanic neighborhoods. The translation for do not sell to minors was no le vendan a las minorías, do not sell to minorities. And you can imagine the kind of situation that could have created in some of our Los Angeles communities when you are from one ethnicity and you're telling we do not sell to minorities here. So that could be very volatile, potentially. We caught that early on. We advised them about this educational materials and made the changes that really were able to alleviate that. We had another series of products that were educational materials where this is why the importance of public health, and the materials were all based on break the chain type of campaign, but that has very not the most positive connotations in some of our communities, and so we said, no, we can't use this kind of material. We need to develop other kinds of materials. And so we develop a lot of educational materials within our shop, and we develop it with the communities in those communities, and really they are part of everything that we do. And so we know that they are much more effective because our communities are very, very engaged in the work that we're doing, and that helps us to make a difference. So this is information on during the past year. Had the retailer received any information directly from the FDA regarding tobacco regulation? And surprisingly, only 43%, 43% said no, they had not. And that's a really high number. However, if you ask them if they were getting information from the tobacco industry, everybody was getting information from the tobacco industry. One of the problems that we are facing, however, is that sometimes our environment, even though not everybody's getting all the information, can also be incredibly crowded. What I'm talking about is that you may be receiving as a retailer materials and information that come from the city, that come from the county, that come from the state, that come from the federal government. And for someone that, is out in the retail world, all of this becomes very, very confusing, and not always are we coordinating all of our efforts together. And so that's a real challenge for us in public health, and something that we need to look at as to how do we better coordinate all of the information that the public is receiving on these guidance and on these regulations. This is Newport menthol use in our communities and the cigarette availability. And as you can see, among African Americans and Korean Americans, it's very, very high, followed by Hispanic populations. The cheapest cigarettes were sold in the African American community. So it's not surprising that you see this when, these cigarettes are sold rather cheaply in some of these other communities. This is the presence of exterior advertisement by community, and as you can see, some of our communities are much more heavily targeted in terms of advertising. I'm not sure if you may remember, but a lot of the advertising that used to be possible, 15 years ago, with the master settlement agreement, became not possible to be advertising everywhere for these cigarettes. And so the retail environment became where the industry focused a tremendous amount of attention in terms of its advertising and promotion. And so that's why we also consider this to be a very important point of accessing for public health. These were some of the perceived barriers to complying with the FDA's tobacco regulation. And it's, this is sort of on us as public health people, no access to educational materials. I mean, we need to be making sure that there is enough materials that are culturally significant and that are, literacy level and numeracy level appropriate for our communities. Something that we thought was interesting, that some customers wanted the retailers to sell them singles or, specific cigarettes. And so they're also, kind of getting some issues related for the pressure that they get from the people that are their customers. And about 30% didn't know what the rules were. I mean, so again, these are all very public health oriented things that could be delivered through interventions and things that could be done in our different communities. In the future, we actually thought this information was going to be different. We thought that it was going to be much larger in terms of electronic media use, that more people would want to receive information in this way. And yet, however, a lot of people wanted to get things through traditional mail or interpersonal. And I have to say that this is the main way, the interpersonal, that the tobacco industry still utilizes in terms of getting information out into our communities. And they go out to the farthest areas to get their information, and yet we're not there, where we also need to be. So the findings from the study can really inform all different levels of regulation from the federal, state, and local levels. And the findings inform the FDA regarding targeted compliance in the retail environment. And before I go on to the next study, there is one thing I want to tell you, which is the reason why we thought the community health workers made a huge difference. There was one store that we went to in particular when we were trying to understand the compliance issues related to the sale of single cigarettes as well, loosies and selling to minors. We found a display, and in the display, there was one part of the display that was covered, and the other part was not. If I would have gone into the store, I would have probably seen that. If I would have been the health department, that's what I would have seen. One of our community workers started talking to the retailer, whom, she knew for a long time, and said to the retailer, but, what's behind this or whatever. So the guy, she took the cardboard that was in front of it and showed to her they were selling loosies, and they were in violation. However, our health department, as well as us, we would have never gotten to that data if it wasn't because our community workers, who are from those communities, know those communities, are part of those communities, asked the question. And so you could also see that by employing individuals that are really in touch with the community, it makes a big, big difference in terms of even the data that you can receive. So our data showed some discrepancy with the state data, with us showing higher levels of non-compliance in some communities, but this is part of the reason why. And I think that our data is probably a little bit more accurate in that sense, because it really showed what was really happening that, can easily be masked within our communities. Any questions up to now? Comments? Feel free to interrupt me at any time. Okay, so I'm going to turn to another study that we have been working on, and this study is funded by the Tobacco-Related Disease Research Program. The Tobacco-Related Disease Research Program, or TRDRP, is the main funder of tobacco-related disease based on monies that we received from Proposition 99, which was the 25-cent quarter that kind of changed the world, because it really made a difference in terms of educational programs by putting that 25-cent tax. And so the TRDRP funds both research as well as a series of other programs. And so we, right before marijuana became legalized in California, we were out starting to collect some of this data, and now we plan to go back and kind of see the difference. You're seeing some of the first preliminary data that we collected, and most of it deals with secondhand smoke exposure in low-income multi-unit housing with this combination of products, both tobacco, e-cigarettes, and marijuana, with the e-cigarettes being the delivery device for the combined products. So this is defined as a triangulum, and this is kind of like the way, the TRDRP defines it. And the purpose of our study was really to work with multi-unit housing tenants in several neighborhoods, predominantly in African-American, Hispanic, and non-Hispanic white communities, understand knowledge, attitudes, and beliefs, behaviors, compliance, and support for smoke-free policies. Again, we work with another cadre of community health workers that are trained to do this. Most of our work takes a little bit of time, but we feel that, it's really beneficial because we get a whole lot more data. We did door-to-door interview surveys, and we also utilize focus groups. So again, this is kind of like a mixed methods approach. So we get both the breadth of the information as well as the depth related to the information. The focus groups are just starting to be conducted, so I won't be reporting on those here. But what we found in the different communities is that those that smoked at least 100 cigarettes in their entire life, look at the rates, how high it is among the African American community in the sample that we had. And so that also became a big issue for us. I also work with the Cancer Center, so I've reported some of this data because they're also working on lung cancer prevention. Do you know, someone who smokes every day or not at all? And again, you see that, some of these communities have higher rates in terms of smokers that smoke every day. This is cannabis use by community and ethnicity, and this is immediately before cannabis was legalized in California. And so you see this by communities, with the lowest use coming among the Hispanic population, but fairly high use among African Americans and non-Hispanic whites. And use of cannabis in the last 30 days, again, fairly high use in the African American population. And so this we asked about, recommendations that came from a health professional. And, it seems like everybody has a health problem. And this is before, so nobody really wanted to admit some things. And then this is e-cigarette vaping by community. And so, again, you see here Hispanics and African Americans and really the non-Hispanic white population with the highest e-cigarette use. And this is vaping by community in terms of currently used some days, again, among African Americans and non-Hispanic whites being higher than among Hispanic populations. To your knowledge, does anyone ever smoke or vape marijuana in your home? And, these were what came out in the different population groups, again, with African Americans and non-Hispanic whites having the highest use. Now this, we started getting a little bit closer to our secondhand smoke exposure and attitudes about smelling smoke, vape from tobacco, cannabis, or e-cigarette vape pens. And it seems that, the smell of these products varies with these groups. And not only was tobacco the one that was the highest, but also tobacco was the one that was most bothersome. So they didn't mind, like the vaping as much or the marijuana use, but tobacco really bothered people. And so that also kind of tells you in terms of the attitudes. And so if the products are being combined, we don't know what all that's going to really mean. Secondhand smoke and vapor exposure in multi-unit housing by community. And so here's something interesting. You've seen up to now that Hispanics tend to have fairly light, lower rates of use at every single thing. But if you look at the exposure, they are among the ones that have the highest exposure of secondhand smoke drifting inside their home. Part of this is because Hispanics in Los Angeles are fairly poor. The majority are renters, and so they are living in these conditions where you have other different communities as well that are, either smoking or vaping, and then they're exposed because, there's this whole thing about having agreeable social relations, and a lot of times they will not confront their neighbors. And so that means that for us, having policies, whether they are policies that are for the housing authorities or policies that are from the city or the state are really important, because then people can always say, well, there's a policy here, you can't smoke. But, instead of like trying to justify, it's my grandfather, how can I ask them not to smoke? And so there is this exposure, which is much higher among Hispanics, although they smoke less. And they have a large number of bans for smoking inside the home, and yet the exposure is higher in their groups. This is a type of secondhand smoke that's drifted into apartment units. And again, what you see here is, especially in the Hispanic Latino community, mostly tobacco, which remember was one of the most annoying, but also the marijuana, cannabis smoke drifting into the apartment. And it's the majority where you see the highest percentages in Hispanics, but also you see among African Americans and other groups as well. So we started moving towards, like edible forms, and what do you think in terms of the preference? And so this is, in terms of, there's a real big preference for the edible type of forms rather than, having smoke drift right into their communities. If a person needs marijuana for a health condition, should they be allowed to do that? And our vast majority believes yes. And so one of the things there is that how do you really distinguish that? If you go down Venice Boulevard, you will see dispensaries left and right, with guys that look really funny. They look like the Hulk, telling you, come in and we'll give you, we'll sign off on something for a medical marijuana use. And so you're not really sure what kind of things you're getting. But this seems to be that there is a difference. People, if you need it medicinally, no matter what way you got there, they're much more amenable to accept that. preference of living in a non-smoking section of a building, you could see that a very large majority prefer to live in a non-smoking section or in a 100% free non-smoking section. So we still have a little bit of ways to go to make sure that the laws that we have in place are enforced, because there are many laws in place now, but a lot of them are not really being enforced in the way that they need to be. However, the preference among tenants and in all of these more housing that are more public housing really have a preference for that. So more than half of our participants have been exposed to secondhand smoke vapor. Most tenants report being in favor of both partial and complete smoke vape-free policies. And people are really compassionate about individuals who use cannabis for medical reasons. But we need better forms to educate on the various forms of cannabis that may not affect other people's health. So to do some of that work at the intervention level, we have another project now that is working with statewide, and it's our Hispanic Latino Coordinating Center. And so the Coordinating Center runs out of our office at the Keck School of Medicine with our affiliate at the California Health Collaborative, which looks over all of the areas that are more rural in nature, and we are more focused in the urban areas. The Coordinating Center's mission is to really improve the health of all Latinos in California by reducing tobacco-related disparities with these different groups. And our services include tailored technical assistance to regional programs, the development of educational materials, testing the materials, and then promoting the materials in Spanish, facilitating policy working groups, and also implementing leadership development programs and developing a policy platform. We have 8 Latino partners that we work with, which are throughout all of California, and they are all within 2 to 3 miles driving distance from one of the central hubs that we work with, because we can't be everywhere. So we really work through our partners and rely on this partnership in order to be able to get the work done. Our promotoras de salud are part of Visión y Compromiso, which is a network of over 5,000 community workers, and they are located all throughout of California, and we have the ability to pull them in as needed to help support the work that we're doing throughout California. Building those relationships takes time, and therefore being able to develop studies of this type also takes a little bit of time, so that we can really work with these communities in a very close fashion. We've been doing a lot of work on smoke-free policies overall. We've also been really working on the creation of culturally and language-appropriate tailored materials. And when I talk about language-appropriate materials, one of the things to consider is not just the literacy level, but I mentioned the numeracy level. And it's really interesting how many folks in our communities not only have difficulty understanding, certain words, but also what certain numbers might actually mean. And so when we're talking about certain percentages or even trying to assess numbers, it becomes a little bit more difficult and challenging, and therefore those are things that we need to pay particular attention to in order to be able to actually develop materials that are adequate for our communities. So with that, that's pretty much it, and I'm open for questions and comments. Thank you. Oh, the panel, okay. Okay, so we'll ask the questions at the panel.
Yeah, we can have if the panelists can come down, and if you want to have a seat with the panelists.
All right, let me get my water here. Hi.
Well, thank you so much for your talk. I think we may need another microphone. I think you can keep that one. So hello everyone, I'm Cerise Hunt. I'm the director of the Center for Public Health Practice, and I'm also the co-chair for the Inclusive Excellence Committee. And so thank you all, and thank you for your awesome talk and presentation. And I'm pleased, we're going to have a reaction panel. And with me, I've riled up some of my dear colleagues to engage in this discussion. We have Dr. Evelinn Borrayo. She's the Associate Director of the Latino Research and Policy Center, and also the Associate Director of the Cancer Center. And then we also have Dr. Patricia Valverde, co-director of the Patient Navigation Collaborative, and also a member of the Tobacco Review Committee. And we are all faculty in the Department of Community and Behavioral Health. So go Department of Community and Behavioral Health. We are represented here today. But before we transition to talk about efforts in Colorado to reduce the burden of tobacco control in the Latino Hispanic community, I just wanted you all to take a moment to react to all the great work that's being done in California. And so would you just want to give us some of your thoughts of what you've heard, and kind of, are there any connections to the work that we're doing here within Colorado?
Thank you very much for the opportunity. My area of research is not necessarily. I am a member of the Board of Health, and so I'm familiar with some of the statistics at the state level, and I would say we mirror California very much in terms of we have lower rates of tobacco use compared to national rates. But when you actually start looking by segments of the population, and very similar to California, when you start looking at ethnic minorities, low socioeconomic status, LGBTQ, we have some significant disparities that surpass national trends. So we do have a very healthy state, and our tobacco use is much lower than nationally, but not by some of these subgroups. So in that sense, I think we mirror. In terms of the work, I think at the state level, we consider tobacco one of those winnable battles in terms of how can we improve the health of Coloradans, and we have identified 10 areas in which we can significantly make a difference, in terms of improving health and reducing some health equity related issues, and tobacco is one of those. And we have been able to make some progress. We have seen a decrease also, as California has, in tobacco use for adults as well as, youth. But like California, we're also seeing that among youth, vaping, and Patty has more experience with that area, but we see it among youth. I believe it went from 15% in 2015 to, or 2005, and then I think it's now 46%. So a significant increase of vaping products among youth. LGBTQ, low socioeconomic status, rural Colorado, it's very much, tobacco is one of those very prevalent conditions that we can definitely address. So I would say we mirror both your struggles and your battles, but also some of the progress and some of the areas that we have identified that we need to target.
So one of the major things that struck me from your talk is something that we really struggle with in Colorado, in terms of the policy decision-making area or level, and that is that balance of population level type efforts, pushing the quit line, that 1-800 number, or, very high level type efforts, and the need for the touch, for the labor intensive work. And so there's always that discussion and debate around how much can we afford in terms of those labor intensive but highly effective types of strategies, like the use of promotoras. And I was at a tobacco conference recently, and, there's a lot of interest in apps and websites and technology, but a lot of our work really comes down to having the people within the communities. And I'm on the Tobacco Review Committee, and so it's a constant discussion around the labor intensive and how many people can you actually reach versus more high level policy work. Not that you can't do both, but certainly with limited fundings, you have to have some priorities. I've been involved in with Dr. Levinson, Arnold Levinson, we did this series of recommendations for our state on how to address tobacco in low-income communities. And we talked a lot about that need for the touch, you need people out in communities, you need trusted agencies and trusted individuals to help with policy, retailer and licensing, to help with cessation, to help with changing norms. We can do some of that using large media and, very large scale work, but a lot of it really does come down to at the community level. And so, we're always talking about that. A couple other things that really struck home as well was the data that you had on secondhand smoke exposure. Here in Colorado, our data also shows that Latinos have the highest exposure to secondhand smoke in indoor work and outdoor work, even with lower rates of smoking. So it's very similar, and that's something that we're very concerned about. And as a result, we, at the state level, focus on certain industries with higher numbers of Latinos. And then also, one other thing was the question about the smell and how bothersome is the smell. Well, I have a cancer center pilot project, and so we're out there interviewing Latino youth around vaping. And so it's interesting how the smell of the vape actually is a big draw. They talk about how it smells like fruits, and teachers think that it might be perfume, but it's actually people vaping in the classroom, and how that's a kind of scary draw that we have to deal with. So I really appreciate you focusing or giving us some examples of very effective community level and hands-on, labor-intensive type work with promotoras. Thank you.
One of the things that we were surprised by was the data that showed how the retailers, for example, wanted to receive their materials. So we've been playing a lot with, text messaging apps and all of that, which is, sort of like the way to go these days. And it seems that there is still an age difference, within some of these types of things and access to some of these, communities. And so, those that are still at one end of the digital divide may still have a preference. And it seems like, not unlike in tobacco and vaping, they're going into a dual use, which, they use, for example, Hispanics tend to use their cell phone a lot. But not necessarily in the way that we use our cell phones all the time, for absolutely everything, because, it's sort of more pay-as-you-go type of thing, so they may not have access to, all the different things that everybody else might have, because it's an economic situation as well. And so that becomes part of it. And so we're still developing, printed materials that can reach these populations. And I also find that we talk about high tech, high touch in our communities, because we feel that you could still use some of the high technology, but the high touch is also needed.
One of the things that you've mentioned is your engagement with the community. And there seems to be a genuine community campus partnership. I've had the opportunity to hear some other talks as well. So would you mind sharing with the groups, just describing your efforts with the 5 hospitals, the connections, the work that the campus is doing to authentically be a part of the community? Could you speak more to that aspect?
So in the last 2 years, we have had major issues at USC, some that you may have seen in the papers. And so we seem to get ourselves known for one reason or another. So I think that as a way to, in part, really come back from a lot of that, especially at our Keck School of Medicine that was particularly hit really hard by those scandals, is that we have a new dean, and our new dean has incorporated a new pillar into the different pillars that really run what happens at Keck School of Medicine. So we have an education pillar, which of course we teach students in MPH and other programs in medical school. We have a research component. We're one of the top research universities, and our Department of Preventive Medicine brings tons of funding in through research. And also we have a service mission. We have 5 different hospitals that we work with, including the Los Angeles County USC Hospital, which is the county hospital. And then our dean has instituted a new pillar in social justice. And so this pillar of social justice permeates, not only does it stand on its own, but it also has to permeate every single area of everything that we do now within the Keck School of Medicine. So one of the hats that I have is as Associate Dean for Community Initiatives. And what that is to really make sure that we are in these communities, working with the communities on a one-on-one basis and really making a difference in these communities. We were, through some studies that we did about the health of the surrounding communities, we actually found that some of our community members in our immediate surrounding areas had worse health outcomes than those in the city of Los Angeles overall or the county of LA. Because of that, we feel that we need to really focus on potential improvements in health outcomes and develop, real strong partnerships. So we have 99 partners that are throughout the entire county. In areas where they're fairly remote areas, and we rely a lot on these partners. I have a strong team composed of about 4 FTEs really, and then that are funded either through the Cancer Center or the Dean's Office. And then we have a whole larger group of community health workers and about a coalition of about 30 promotores de salud that are all paid through grants or other stipends or different mechanisms to ensure that they are able to operate at their local levels. And we have trainings, we have, like I said, we've even translated entire IRB protocols to make sure that they are able to be certified and to do the work at the community level. And so we work very, very closely with our partners and with our community workers, and the commitment is there at every single level within the medical school, from the dean's office to our cancer center to our Department of Preventive Medicine, which really are the ones that are out there doing this kind of work.
Okay, and so thank you. And so thinking of the work and the efforts that are being done within Colorado, what are some of the successes, or what would you deem successful approaches that have been put in place to address tobacco control in our Latino Hispanic population?
All right. So, like I said, I'm on the Tobacco Review Committee, but also I'm a researcher and a tobacco treatment specialist. So I'm particularly interested in cessation. And I had mentioned that I have a small cancer center grant looking at vaping among Latino youth. And so it's a mixed method study, and the hope is to develop an intervention that could be used in communities with majority Latino populations or youth. So youth vaping is a major issue right now. Obviously, the state is taking it very seriously. So over the past few years, there have been a number of efforts to develop youth targeting media and social media campaigns to try to help change the norms around vaping. What we're finding in our data and in our focus groups is that there is that perception that everyone vapes because they see it all around. And even though the youth that are in our study are not necessarily vaping, maybe less than a quarter, but still that perception is that everyone does it. So there's a lot of efforts that have to happen in order to try to reduce the prevalence of vaping among youth, and especially among Latino. We have to change norms, and so that's kind of underway at the local level, as well as state efforts. Like Heather here, she has a youth social justice project that looks at tobacco and nicotine use. We also need cessation interventions, and our Quit Line now has integrated vaping as part of the Quit Line intervention or treatment. The problem, though, is that the youth don't see themselves as smokers. Vaping is viewed very differently than cigarette smoking, and so why would you call the Quit Line? So there's a lot of kind of efforts that it's going to take some time to change those attitudes and perceptions, and also awareness. So we're hoping to move forward in developing interventions around cessation. There are a number of prevention, like school-based prevention efforts out of California, out of Stanford, and other parts of the country that I think now at the local level they're starting to look at if they can implement it in their school districts. So for youth vaping, it's still very much evolving as how to deal with that, both at the local level and at the state level, with the emphasis around norm changing, media, access to cessation. For adults, we have, so the Tobacco Review Committee, we distribute about 19 to 20 million a year. The funds that are available to tackle tobacco in Colorado are declining, and at the same time, the use of vaping or electronic cigarettes is increasing, and we don't tax those. So we have this kind of, future problem coming when we have less revenue to spend to combat nicotine and tobacco use, and at the same time, we might have an increase of people who are on e-cigarettes moving into cigarettes, or youth, moving into adulthood and cigarette smoking. So we're kind of in a precarious situation right now, and hopefully we'll address that soon with regards to taxing of e-cigarettes and vape devices and e-juice and all of that, as well as other policy level work around increasing the age of access to tobacco and nicotine to 21. So there are a number of policy level work that is happening at the local and at the state level. We have put a lot of money and effort into health system changes. So, for example, at Denver Health in the city and county of Denver, which has a large Hispanic population, they now have tobacco clinics throughout their system. Maybe 10 years ago, it was typical just to refer everyone to the Quit Line, and now we're seeing a lot more tobacco cessation treatment being offered at the federally qualified health center level, which again is so important because you need that personal touch. For some people and other people, a phone call is sufficient. We distribute funds to all of the local public health agencies so that they can also work on both cessation and policy level changes and work on attitudes and prevention. So there is a lot of work to be done, especially around vaping. But as Evelyn had mentioned, our cigarette smoking levels are pretty good. What we're concerned about is at some point, does the vaping and the e-cigarette use start to shift back into or over to cigarette smoking?
So that's quite a bit. The only thing I would add is in terms of what we're doing locally at the state level, I think one of the most effective things we have done as a state is the Amendment 35 funds, which is really the tax funds from tobacco products. And that has been quite successful in that money is mandated to go back into the community and really improve the health of communities, not just related to tobacco, but to improve health equity across. And at least I know with the tobacco, we approved 26 grantees at this point in time that represent several communities throughout Colorado, and those are the people that are doing the work that you were mentioning, Lourdes, whereas they're into the community, they know their community, they know what the needs are, and we have so many more people that apply, but these are really people that are doing work for the communities, not research based. So Amendment 35, and we've done such a good job that our funding has actually decreased for some of those programs, as some of us know, and so it's good and it's bad, but at the same time, we're able to use some of those funds for the community. So that's what I would add.
Can I mention a couple other things?
Yeah, because one of my questions would be just to add on, and you may be able to address this. So are we seeing the disparities that we've seen in cancer, because those were designed to address like the disparities in cancer, cardiovascular disease, based on these funds that have been in existence, I believe, since 2008, 2005. Have we seen, 2005, have we seen a reduction in the disparities within our Latino Hispanic population?
So I think the other thing to mention is we do some strategic planning around tobacco. The state does. When I said we, I have my state hat. We do, the CDPHE, the Department of Public Health and Environment, does strategic planning through the review committee as well as, comes to the Board of Health and set priorities. But that is revised every 10 years or so, where we really look at what the trends are and what the disparities. And so that has been adjusted with vaping really becoming a more recent development. But before, we have been able to tackle some of those winnable battles and seen a decrease for the last 20, 30 years, a significant decrease in tobacco use as well as among youth. What we're seeing right now is this increase in vaping for the reasons that Patty mentioned.
So here's a question for all of you. What is a tobacco-related health disparity? And are there disparities? So my first study in a population in New Mexico was looking at smoking because the lung cancer rates were far lower in the Hispanics than the non-Hispanic whites. If you look at African Americans, the risk for many tobacco-related cancers exceed what you would expect based on smoking patterns. So I don't have the answer, and it's worth discussing, but I'll challenge you to give your thoughts. So what is a tobacco-related health disparity? It seems like we have multiple epidemics in progress with different consequences for different groups. Disparity implies that somebody is doing worse than you would expect based on something. And that counterfactual is often non-Hispanic whites or whatever the majority is or everybody. So we use these words, they're convenient, but particularly if you put in the context of the very different smoking patterns and the very different disease risks. The latest study from the multi-ethnic cohort at USC, University of Southern California, shows, in fact, that this persistence of excess beyond expectation lung cancer in African Americans compared to other groups, taking into account smoking. So help me out. What's a tobacco-related health disparity in 2 words or less?
So for me, the disparity goes beyond just a difference in terms of the whatever the prevalence or a difference between the populations, but it's also something where we can actually do something about, and that there's something that's preventable that we can actually act upon. So there are many disparities that we do not want to be similar to any other group, I mean, actually, if you look at the health of immigrants on some indicators, immigrant population populations are much healthier than other population groups. So even though that is a disparity in terms of a difference, certainly we do not want to equate what that might mean for our populations. But there are other indicators where we can do something about. And one of the things with some of the tobacco-related disparities deals with, for example, when you see exposure to secondhand smoke, when you have a population that has bans on smoking, has low rates of smoking, and yet they're being exposed at a much higher rate without, anything that they are doing or that we can do, or that they know what to do at the moment, and that where we can make a difference. So to me, that shows like right there, we can make a difference in terms of exposure to secondhand smoke in Hispanic populations. Some of the things that we're doing, some of the work with Jennifer Unger, through accessing different communities in multi-unit housing so that we can actually train them on, how to advocate better for their own health, and how to work with tenants and how to work with the housing authorities to make sure that the laws that are in the books are actually implemented. So we can make a difference. We can change that differential of exposure, that we have in that population. So it's kind of like adding that to the definition as well in order to really make a difference in it. Do you want to add anything? No?
Yeah.
Sorry, I'll continue the conversation for a moment, because I still think that we use the word disparities too loosely, and for example, let's stick with the Hispanic population for a moment, where women will tend to smoke more lightly and less. So that's a good difference.
Yeah.
It's not a disparity, but what I would say is when you target tobacco control, you want to try and preserve and protect this low prevalence, and it's a different course of action that you would take. So, we have differences. Seemingly, we have differences in how the industry behaves with different groups, targeting African Americans with mentholated cigarettes, good example. We have differences in biological responses, perhaps, the excess risks in African Americans, which remain not very well explained. And we have differences in smoking prevalence that maybe reflect some confluence of factors that are cultural, industry, targeting, marketing, and other things. So I don't know whether we can bring more precision to the discussion, because it could be useful.
Well, I just wanted to give an example based on what Lourdes had suggested, and that was, for example, if you look at Latinas, our smoking rates are, pretty low. Fortunately, Dr. Levinson, in 2015, when he analyzed the adult tobacco survey data, he differentiated between English-dominant Latinos and Spanish-speaking dominant Latinos, and we see very different rates. So the Spanish-speaking women smoke at very low rates, Spanish-speaking men a little higher, and then it was more the Chicanos, or the more acculturated and second generation on Latinos that smoke higher here in Colorado. But for example, so we're able to disaggregate really what is that group within Latinos that potentially have disparities and which have more protective factors. But if we look at, for example, women who are pregnant and smoking, we see in the rates that Latinas, so we don't know if they're English or Spanish speaking, they actually relapse after delivery at much higher rates than other women. And when we look over time, the rate was pretty high, and then it went low, and then we're starting to creep back up. So, that is a rate we want, as low as possible, so that once they quit during pregnancy, they'll remain quit. But when it's, starting to trend upwards, then that should be a major concern, regardless of, how it compares to other groups. Actually, we should be wanting to push that down as much as possible.
I think, just briefly to answer your question, we define disparities when individuals are disadvantaged by their position in society. So if there is any difference where a group is disadvantaged because they're of lower socioeconomic status, race, ethnicity, that's how we define those disparities versus just the difference. I think that's what you were asking in general, how we define those disparities. Yeah. Then there are those examples, you know.
I could add just a little bit more to that related to the disparities. For example, not in this realm, but more in the realm of the work I do on cervical cancer. So we have much higher rates of cervical cancer among Hispanic women in the Los Angeles area. Now, here is, then that's followed by Korean women, then African American women. And so when you compare them to non-Hispanic whites, one of the key issues in that is not just healthcare access, which is an essential part of why those disparities exist, but also access to information. And so here is a cancer that nobody should be dying from these days, and something where we can make a huge difference in, and where we could really tackle, sort of this differential that exists in that population. But it requires an effort at multiple levels. It requires an educational effort with the communities so that they're educated about these issues. It requires an issue to move them to action about HPV vaccinations. It requires women to come in for screening after a certain age. And so it's very complex. And to have the medical system on board to be able to support the kinds of services that will be needed for these populations. So tackling these disparities, going beyond the identification, which is part of what you're getting at, but also trying to understand why they exist so that we can find the right solutions is really part of our task these days. And so I am really hopeful that cervical cancer may be eliminated within my lifetime. And I think that, we made a huge dent when it came in terms of tobacco. I mean, some of the work by Stan Glantz actually showed a difference in cardiovascular disease in terms of a much faster rate of reducing bad health outcomes related to cardiovascular disease because of tobacco use. And I'm really just hoping that this vaping thing is not just turning the whole thing around and creating larger disparities among our different groups. Because if you look at youth, Hispanic youth is vaping at a pretty high rate, as well as other communities that this is getting to. And so I think many of our populations right now are at incredibly high risk. I don't know if I want to call it a disparity, but it's becoming so prevalent that it is really something of incredible concern to all of us in public health.
Thank you. A very enjoyable presentation and series of comments. 3 observations, any of which I would welcome your reaction to. The first is going back to John's comment about tobacco-related conditions and mortality. Among American Indian, Alaska Native people, we have this conundrum. We have in many areas, very low rates of smoking, but we have high rates of what would be classically considered tobacco-related mortality in the contributing conditions. And I think and so people have been trying to understand that paradox. And I think the paradox is best understood by what you just said a few moments ago, is that the detection and management of those cancers is very poor in those communities. Those individuals do not present to the health systems early enough, and once they do, the cancer stages are so far along, and the lack of access to tertiary care is so poor that the mortality is substantially greater. So it's a really interesting conundrum when you try to move from population data down to these kinds of mortality consequences. So that strikes me as interesting. There was the earlier slide when you were talking about the American Indians who are in your survey, and you showed the high rates of cigarette use. I was really struck by that because when you, in another slide you followed up with, you showed very high, I think the highest level of education was among American Indians, unless I've confused the two studies.
Was it among non-Hispanic whites?
Was it?
Levels of education? Oh, do you mean the literacy? Levels of educational health literacy. Yes.
But it is a general observation, isn't it, that the higher the level of education, the lower likely prevalence, correct?
Right.
So that I was trying to make sense of that, but also teasing out what are the correlates of that in terms of socioeconomic status and the subsequent access to care and likelihood to engage in detection and management. One of the other interesting issues, and we talked briefly about it this morning, is there's enormous geographic variation among tribal communities. I was sort of like puzzling through the one slide that showed all of the states with the various color-coded levels of prevalence of smoking, when in fact the data that I'm familiar with shows that North and South Dakota are among the highest states with prevalence of smoking with American and Alaska Natives, and southwestern states are among the lower. But so it was really interesting to try to make sense of that discontinuity with what, and so I was trying to figure out, you had NA
what
for...
data is included.
Okay,
right?
great.
Yeah.
So I'd be interested in your reaction to any three of those observations about geographic variation. In the same vein, when we've looked at tribal communities and the prevalence of smoking or any other kinds of behavioral health conditions, when you compare regionally and nationally, we often come up higher. But when you actually compare to the geographic counterparts of non-Hispanic whites adjacent to those tribal communities, they're almost indistinguishable. So it moves us back to this question about the social determinants of health that are active in those particular contexts.
Right, and I think one piece that you also touch upon deals with a lot of the cultural aspects of how tobacco is used or not used in some of these communities, and the importance of the product itself for these communities and the value of it at different kinds of levels. And, as we discussed earlier today, how do you prohibit a product when in some of the tribal communities it's part of health and healing, and it is something, and it's very confusing to deliver, what kinds of messages to deliver. But so I think that we still have a lot of work to do. In terms of the maps, I think it probably depends a lot on what data is included. As you know, a lot of times either American Indians are left out, or Hispanic, Asian, or Asian Pacific Islanders are just, different. And so different data sets might have different ways of doing it. And I think, I think you're right on in terms of the presentation of some of these conditions and the morbidity and mortality in our communities. It's just really bad that, people are not coming in, even when the services are available. Now, we haven't said that the services are acceptable, which is saying that they're available for people. So, you talk a lot about the cessation and the quit lines, and, if people are not feeling that they really are susceptible, why am I going to call a quit line? It just doesn't make any sense. And so creating that educational awareness and also understanding the cultural factors. I mean, I remember a few years ago, if I went back to Santo Domingo, if my uncles, if I didn't bring them cigarettes, it was not a good thing. It was like, ¿qué me trajiste? What'd you bring me? And it's got to be, American cigarettes of some kind. And that, things have changed. So, it's also, there's a lot of cultural aspects to a lot of these issues that we've barely even started to touch upon.
So. Just a week before last, we had NIH, Health Service, and CDC sponsored a conference of traditional healers here. And we had 40 traditional healers from
wow.
the country.
Oh, my goodness.
2.5 days. And it's our tradition to underscore and the contribution that each gives to these kinds of gatherings by various kinds of gifts. And an urban American Indian gave a packet of spirit cigarettes to one of the traditional healers who rejected that, and then used that opportunity to educate everyone present about that was the commercialization of the sacred, good, and the lessons that were part of that. It was very, very fascinating.
Very, very fascinating.
So are there any questions from the audience other than Spiro and John? I'm gonna cut them in this last 5 minutes.
So on one of your background slides, you were talking about marijuana use in high school students in California, and I think the rate you had for Hispanic high school students was close to 50%, which is interesting to me because that's significantly higher than the average rate, which I think is closer to about 35% of high school students. But then when you look at adults, there's significantly lower rates than average. So my question is, one, what do you think is driving this shift from higher than average rates to lower than average rates? And what can we take from that and apply to either other racial or ethnic groups or something like vaping or something that's not cannabis use?
I think it has a lot to do with the attitudes about the different products. And part of it is that tobacco, in the Hispanic community may be seen as a whole lot more harmful. And so, if you have a ban against using tobacco in your home, that's one thing, but you may not feel the same way about marijuana, and therefore you may not necessarily enforce that because it's more of a natural kind of product. And so I think that, just from personal anecdote with families that we've worked with, they will say, well, I prefer them to be, smoking marijuana than smoking tobacco. And so in that sense, there's a little bit more lax attitude. And I think that it's possible that that might be where some of that might be coming from, in terms of the acceptance of the products. Tobacco is still seen kind of like, we made a difference in making sure that tobacco was seen as something that's bad for your health. And so, we have not done that in terms of marijuana use, and I think that the attitudes of people make a difference. I don't know if you have something.
I'd like to add on because we're doing an analysis of our youth survey, the Healthy Kids Colorado survey, and so we're looking at Latino youth who vape and use marijuana, and what we found so far is that the influence of the parents or the environment was more predictive or had a greater impact on Latino youth than non-Latino youth, and perceptions of harm and risk of vaping and marijuana had less impact on Latino youth. So it was more the household or the family as opposed to views around harm that influenced their rate of vaping and marijuana.
So the lax attitude, more lax.
Mm-hmm. Yeah.
Thank you.
I also wanted to mention one more thing. I think in addition to cultural aspects around tobacco use and nicotine use, we also can't disregard the effect of daily discrimination and experience with racism among our Latino community and all communities of color. And, we see nationally that immigrants, here in the U.S., the longer they're here, have worse outcomes and poor health behaviors, and with subsequent generations, higher rates of smoking. And you can't deny that there's some level of, daily stress and discrimination that impacts those health behaviors. And we need to address it, and we don't.
Be responsive. So I hear the social determinants of health when we think about those different aspects and ensuring that the interventions that are put in place are culturally responsive. So if we can have some interventions, we can have these different services, but if people from the Latino, Hispanic, our communities of color feel as though they're not accessible, that they're going to be treated, because our research still shows us that people of color do not receive the same quality of care due to the bias of the provider. And so with that being said, that's part of that discussion, that we can have these interventions. But one of the things that I appreciate about Lourdes' talk is they were all culturally responsive. There was that cultural aspect. We cannot have that one shoe size fits all mentality to our public health approaches, because that's what I think contributes to the poor health outcomes and the quality of care and the historical aspect. These trends that we're seeing within these populations have a historical component to them as well. Are there any other questions as we go into this last minute? This will be our last question. No, it's all good.
It actually follows yours really well. What I was curious is, all of this is interconnected with so many different industries and professions, and so I think it's amazing to do all the community education and the interventions that are happening, but is there anything already in your curriculum for the students? Are we talking to healthcare providers on how to be more culturally sensitive, appropriate? all of that because I think it all intertwines.
You just touched on one of my favorite topics. How much time do we have? Okay, so one of the things that our medical school is actually doing is from the orientation week that our medical students come in, they have these, they're embedded within about 15 to 20 of each. In our entering class of 186, we're embedded into community organizations during the first week of orientation in order for them to really get a feel for these communities and what these communities are like and what it means to work in these communities. In addition to that, we're testing a pilot project right now, which is called Adopt a Student. And what it is that our community families, through our community agencies, who are multi-generational, will adopt a medical student for the entire term of their medical school education for the 4 years. This is not the student adopting the family. This is the family adopting the student so that they could be the broker of health for that family with the medical system, especially our LA County system. And then our MPH students are really trained to be out there, working with our communities. So I love that part of the work that I do.
For those of you who are interested in Latino health here in Colorado, we do have the Latino Research and Policy Center, and we actually have a course on Latino health, and it's a 2-semester course, and part of the course reviews tobacco as well as all sorts of other social determinants of health and health conditions related to Latino communities and subpopulations within Latinos here in Colorado and across the country. For tobacco-specific work, there is here on campus, actually within Cerise's Center for Public Health Practice, a tobacco group that has developed online modules. And I've met patient navigators at various community health centers around the state who have received training on tobacco control and even some level of cessation training so that they can work with patients at their community health center. Also on campus, we do have one of the tobacco treatment specialist trainings. There's several throughout the country, and we have one here. And through funding from our state tobacco program, there are limited scholarships. So there are a number of, I think, training efforts going on around on this campus and throughout the state around tobacco.
Yeah, at the state level, we're also recognizing the importance of behavioral health, and it has become one of the strategic initiatives at the state level of really bringing behavioral health to primary care settings and communities, and some of that is to identify some of those behavioral issues that before, unless it became an illness, then we wouldn't identify it. Now we're really trying to be proactive, particularly with youth, and really recognizing what are some of those risk factors for youth, as well as, doing some screening for youth, tobacco use, for example, mental health, other things that are now included. And that is one of the newest initiatives at the state level, is integrating behavioral health.
Okay. And as part of that, can I just add on?
Just 30 seconds.
Okay. So the tobacco group is also funding tobacco control within behavioral health settings because, for many years it was kind of hands-off in terms of limiting tobacco use and nicotine use in behavioral health programs. And so that's a big effort right now through the state tobacco control.
Okay. Well, let's give our panelists a hand, and thank you so much for sharing about your work. Okay, and thank you all for participating. Have a great evening.